Let me try just sending this to Dr. Bullock one more time.
Because you all have the same email address as her, right?
Yes, so.
Yeah, so it's.
I'm just
well,
gonna
and it's funny because I don't even see Aya on the invite, but you're here.
Yeah. I got a Google Calendar invite. I'm not sure, Kate might have sent it or something.
She probably forwarded it to you.
Yeah, I was able to send Aya an invitation, but.
Yeah, because Dr. Bullock is right. She's in the invitation.
Oh, it looks like somebody joined. Is that Dr. Bullock?
No.
Oh, okay. It just says meeting guest.
Can you ask her, did she receive the invitation I just sent her again?
Yeah, I'm just texting her now to see if she got it. Okay, she hasn't responded yet, but.
Because if necessary, I can quickly see if Charlisa could set up a Zoom call instead of Teams.
Yeah, let me call her one more time and just see if she was able to get things together. She's just trying a different computer.
It looks like she might have joined.
Yep. Now it worked. We're good. Welcome. You're on mute, though.
All right, can you hear me now?
Yes.
Yes.
Okay, I can give you a tour of my house because I had to go get another computer for some odd reason. Okay.
Just so you know, this is being, I think you all usually tell me this, but this is being recorded and transcribed. And at the end, the recording and the transcription are immediately available to anyone who's in the meeting.
Okay. I thought you were going to say it's going to be available to anybody for public records so that they could see my house. Okay.
Great. So Dr. Bullock, we're just waiting for you, but we can talk a little bit about the framing of the study. So we have been interviewing a bunch of different providers, practitioners, and key professionals in the DD space. And obviously you are an incredibly important person in that community, so we wanted to get your perspective to better inform our study where we're looking into the health barriers or barriers to healthcare for individuals with IDD during the pandemic. And so we're excited to hear what you have to say about your experience during this pandemic and coordinating care and trying to do this at more of an administrative level. Dr. Bullock, do you have anything to add on top of that?
Nope, you were very clear and complete.
Can I ask one compound question?
Yeah, of course.
I think you had said before that the interviews are anonymous. Do you
But
identify the source of the information? Because there is only one person in my position.
We did talk about that. Since there's only one person, the way we are transcribing the information, we would have, because you are the only person, we would welcome you to review that to see whether there would be any identifying descriptive analysis that would trace back to you. But the way we are looking at these in terms of analysis, it is one with coding and thematic description and identification. So your themes would be grouped within an administrative block, but those would be looked at within the context of how often those themes would appear. Now, if there are unique features that you describe as a result of a question asked, we would certainly allow you to look at the way we have discussed that, not necessarily transcribed it, but discussed that as part of the analytics to see whether there would be any identification by your comment. Does that make sense with that long-winded answer?
Yes, thank you. I just want to,
Yeah.
I want to be as thorough in my responses as possible, but I want to make sure that I'm not worried about who's thinking what as I respond.
Right, and we address that with both you and Winslow, and we do have someone who's going to assist us with the analytics from a qualitative perspective so that we are staying true to the thematic construction that we're using for our methodology. Yeah.
Great. Okay, thank you.
If we decide that you've said something brilliant and we would like to publish it, obviously we would ask you and say, Andy Reese, we liked this phrase or this comment.
So before we get started with any questions, we do have to go through an informed consent process. So I'll just read a script to you, and that will give you all the information about the study and allow you to consent to the study. So I'll get started with that. Hello, my name is Kate Williams, and I am a student researcher in Georgetown's Community Health Division. We are researching the interventions employed by lay advocates to help combat the challenges the COVID-19 pandemic has posed to individuals with ID. I am interested in your experience as a key provider for persons with ID during the pandemic. The purpose of the study is to come up with lessons learned and best practices for providing care to individuals with ID, especially in recognition of the disproportionate case and fatality rate experienced in the ID community due to COVID-19. The study will inform community service providers and clinicians of best practices in providing care to this population. We are hoping this can serve as a basis for suggestions for policy and practice in healthcare delivery to adults with ID during the current pandemic as well as in future crises. We estimate that approximately 40 providers will enroll in the study. Your participation will involve one interview lasting a maximum of 2 hours. Sorry. We will ask you questions about your experience providing care to members of the ID community during the pandemic. The interview will be recorded in order to have an accurate record of the information provided. If the interview is conducted over Zoom, you will be given the option to have your name and video displayed. The study has minimal risks for participants. However, you may feel uncomfortable answering some interview questions since they will relate to your experiences during the COVID-19 pandemic. You are not required to answer any questions that make you feel uncomfortable, and the interview can be stopped at any time with no repercussions. There is a small risk of breach of confidentiality, but all efforts will be made to keep all of the information confidential. You will not be identified by your answers, and all of the responses collected during the interview will be stored in a secure location. If it is okay with you, we may want to use a direct quote from your interview, but these quotes would only be cited as from a participant in our study. Once all interviews have been completed, we will group all answers together for any form of presentation or publication. There will be no way to identify you as an individual participant. There are no direct benefits to you from taking part in this research. However, possible benefits include providing you with an opportunity to voice your experiences, opinions, and concerns around the handling of the COVID-19 pandemic as it relates to the ID community. Do you have any questions about the study?
No.
If any additional questions should arise about the study or your participation in it, please feel free to contact myself or Dr. Bullock. Do you agree to participate in the study?
Yes.
And do you consent to having your interview recorded for data collection purposes?
Yes.
Great. So we'll get right into the questions. This first
Sorry,
yes.
Do we need to change Andy's name? I mean, although we went ahead and started the recording and your name is right there.
I'm not the host for this, so I cannot change.
Oh, okay. So Andy, that's up to you. Theoretically, what we've been doing is giving everybody a number and then starting the recording. But since I didn't realize, I jumped on obviously late because of technical problems. I didn't realize that you were actually hosting so that means that's up to you whether you want your name right there as opposed to a number.
I'm fine. I tend not to keep too much to myself anyway, so I don't imagine I'm going to say anything that I haven't already said publicly.
Okay.
Okay, sounds good. So we'll start with just the first set. This is just basic demographic information. So I'll just ask, what's the name of the organization that you work with?
Department on Disability Services.
And what type of organization is it?
In regard to this study, we provide wraparound supports for people with intellectual disabilities who live in the community. We also have the vocational rehabilitation program for all people with disabilities to help them achieve an employment outcome. And we also do the medical determination for Social Security disability claims.
How many people does your does DDS support?
In terms of supporting people with ID, currently right around 2,335.
Great. And how many staff members work for DDS?
For DDS, there's currently about 380, but within DDA, directly supporting people, service coordination is 80 service coordinators and 10 supervisors. And then we also have intake staff, investigation staff, quality staff, nurse consultants. We have 10 nurse consultants. I think that about covers it.
Great. And historically, how long has DDS been supporting individuals with ID in the district?
So DDS as an agency was established in 2006. But prior to that, MRDDA was an administration within Department of Human Services, and that went back decades.
Great. And of course, we'll ask, what is your role in the organization?
I'm the director.
And how long have you been with the organization?
I've been with the organization since 2011. I've been the director since 2016.
What roles did you serve in prior to being the director?
I was the deputy general counsel for 1 year, and then I was the deputy director for the Rehabilitation Services Administration, and then I became the interim acting and then director.
Great, thank you. So the next set of questions we'll move into have to do with different processes that may have been undertaken during the pandemic. The first question that I'll ask is about how many months, days, or weeks into the pandemic did you realize that DDS was requiring additional support to carry out its expected duties in supporting individuals?
Immediately. It was like March 20th. I mean, just as everything, I'd have to go back and look at my calendar to remind me, but it was, things shut down pretty quickly and day programs were closing down. We recognized the need to have to provide staffing in the home because people couldn't go out. And so we immediately had to make significant shifts in our programming. Because I remember sort of getting our first briefing in late February and having our first community forum in early March. So.
And so about how long into the pandemic did the provider agencies start maybe coming to you or to coming around with different issues that were requiring support? Was that about the same time?
It was immediate.
Mm-hmm. And what were some of those challenges that started coming about right at the start of the pandemic?
Staffing, how to figure out staffing, because initially and even to date, people who have restrictions on their ability to travel into the community still. Prior to the pandemic, people for whom we provide residential supports would be out during the day. And so our rate structure for residential supports is based on an 18-hour day as opposed to a 24-hour day. And so we had to immediately make that change. Staff agencies had to find personal protective equipment. You may remember way back at the beginning of the pandemic, all of the discussions about whether people needed face masks or not, who needed them and when. And so, we actually had one provider whose director, their education was in public health. They were prepared. They had purchased all this equipment in advance because they just had it ready. And so they were ready to go. But others, you may recall, 2 years ago when people were making face masks, and the whole question of when they became, initially when they became available, they were for healthcare providers. Were our staff healthcare providers or not? So we had to deal with the Department of Health around those issues. And actually we're able early on in the pandemic to work really closely with the Department of Health around resolving some of those issues. One of the benefits being that they are responsible for doing the monitoring. We have people in different types of placement. Intermediate care facilities are the most restrictive placements, and then residential habilitation is like a group home, supported living, and then people who live in their own homes, and we provide supports there. People who live in intermediate care facilities or ICFs and ResHabs, those are licensed by Department of Health. And so they were involved with those. And so they had to help make sure that they were up to a particular standard. And so that did help us with getting access to equipment, because if you're going to require them to do certain things, you have to provide them the means to do it.
Right. And so as the pandemic progressed, did you start to notice that the issues being faced were shifting away from maybe from the PPE access to other issues? And if so, what were some of those issues that were coming up?
I'm trying to remember back because I remember like issues around getting vaccines, but that was way into it. I mean, initially issues around education for everyone about what they did need to do, making sure that providers were aware of what were the steps they needed to take, what were the steps that needed to be taken whenever there was an infection in a home. How did you make sure that, you know, when people needed to be isolated, that you had the provisions to do that? You know, that people being discharged from hospitals, could they safely go back home? How were we going to provide services? Because we immediately also shifted to 100% remote provision of services. And about 900 of the 2,300 people we support live in their own homes. So figuring out how you're going to provide services to people who are in their own homes. We early on, Centers for Medicare and Medicaid Services with waiver supports they provided for flexibility that you could ask for in provision of the services and additional payments for things that were costing more money. So we had to figure out what kinds of flexibility we needed in our service provision. You know, like requirements for licensure for people, you know, for people who were direct support professionals who first start working have certain things they need to do in order to be eligible, in order to be qualified to do the work. Well, some of those things were not available in the beginning of the pandemic. So we had to identify which of those couldn't be done, which of them could be done remotely, which could be delayed. We
Right.
thought, if you recall, that this would all be over by June 2020.
That, yeah.
And
Yeah.
so, yeah. And I'm just curious when we, yeah, our first person was diagnosed near the, oh, wow, I forgot all about like testing. You know, early on, there wasn't wide availability of testing. So figuring that out. Our first person was diagnosed March 26th. So that was when, for us, sort of it got started. And we had an explosion of cases in April. We had a huge number of both infections and deaths in April. And so figuring out with those how to respond.
Yeah, certainly.
So it
And
was all, that was all kind of crisis management.
Mhm.
Later down the road, we get to more of the, and how do we live in this thing? But those were all the things around just how do you prevent people from getting sick and dying?
Mhm.
right. And so as the pandemic progressed and you started to come up with different solutions, what types of solutions did you find were effective to protect individuals supported?
Well, and not only protecting them, but going on with their lives. And it was interesting because, I mean, even going way back, we had discussions with people. While most everything shut down, not everything did. We had some people who worked at grocery stores. Anecdotally, I have said to people, the folks who I've spoken to, who we support, who seem to have weathered this psychologically the best, were the people who were working and continued to work because they continued to get out. Their lives were less disrupted. They really, you could see the difference in their affect for the folks who were able to engage in the community. And so we had to confront issues around how do you help the person with their support team make a decision about what they're going to do? Because, you know, we have a system that has a long history of doing what's best for people, whether they like it or not. And so helping to recognize that the person may have a decision, may have a right to make that decision, And how do you kind of work that whole thing through? And we went to court on a couple of those where we had a person that wanted to go to work and they had a guardian that wanted to stop them. And we supported the person's desire to return to work because they had considered all of the issues and decided it was what they wanted. And they did it with their team. So those were some of it was really about how to help people keep, like, how do you keep people engaged? How do you provide interesting, engaging things to do during the day? How do you keep people from just sitting there all day? Like I said, it's no longer about just keeping them from getting sick. But people do need to be physically and, psychologically, intellectually engaged during the day. And I know I thought one might think providing supports for the people that we support, it's the same day program, residential, but it's not. And, the day programs are used to programming an engaging day for a person. And if you think of yourself, I know for me, the people we support in residential supports, they go home in the evening. They get dinner, they watch television. Their evening might look a lot like mine does, not very engaged. And so you need to make sure that you're still engaging people while also making sure that the protections are in place to keep them safe. And this thing, as you know, has evolved and apparently continues to evolve. And so continuing to provide education to everyone about the current state of, knowledge regarding COVID-19. Because for our provider staff, it's been really hard to keep up with what are they supposed to do now.
Right.
I'm trying to sort of remember back and go kind of in order, but because, there were a couple of times that I believe it's true that it was June of 2020 that we developed. You may recall early on, the city worked with Johns Hopkins to develop this plan. And it was in phases of returning to, I don't remember what, but we had our phase 3 plan ready to go. We never got past phase 2. But we had that ready to go, like a draft ready to be reviewed by the mayor's office in June of 2020, because we thought by July, August, day programs would be up and running again. And we were thinking that in the summer of 2020.
Mm-hmm.
Right. So did you notice that, or when you structure these different public health solutions, were they different between different facility types, such as was education for staff working in an ICF different than staff supporting someone who's living at home?
The education wasn't, the requirements were.
Mm-hmm.
It's also very interesting throughout the pandemic, the people who have fared the best, the people with the worst documented record of vaccinations and a very low rate of getting boosters and have had the best health and the lowest COVID rates are people who live at home. So it's been a mixed bag, but people living at home very often have been the families of people who are living at home have been very protective of those people. And I expect some of that protectiveness has extended to not being open to vaccination, unfortunately. So that kind of education for families is very different than the education for DSPs and for, we have regular nursing roundtables for all the provider nurses.
Right. Yeah, certainly.
And like I say, it's always changing.
Yes.
Which is frustrating because, we try to keep up. And now that we don't have our weekly forum anymore, we don't talk to DC Health as often as we used to. And it continues to evolve.
And more broadly speaking, did you notice that, or were solutions in general for like some of these public health problems different between facility types?
Well, in part, yes. Good and bad in that in the larger settings, you did have the ability, like people had other people they were living with to interact with. Where people were in supported living and there were very few people living together, you'd be more isolated. And so while there's fewer restrictions on them, they potentially are more isolated because there's just, even when there was the ability to go out, there wasn't much to go out and do for any of us. And so for people who were living in an ICF, if there were 5 or 6 people living together, at least they did have people that they could interact with and engage with, and there were activities they could do. So that was a positive thing. Now, the restrictions in those homes were stricter because, generally speaking, people in intermediate care facilities are medically more complex, much more at risk for serious outcomes, or coming in contact with someone who's at risk for serious outcomes. And so you have to be much more careful there because you don't want to introduce COVID into the placement.
Right. Yes, certainly. And so as these different measures and solutions were being introduced, how did DDS measure compliance with all of this and the mandates?
So we maintained our monitoring visits by the quality resource specialists who monitor homes, as well as service coordination. Those were done remotely, though. And so 8 months into the pandemic, we started doing them in person. And we were doing sort of spot checks. By we, I mean that literally, like the supervisor for quality resource and I would go out and visit places, and we would check on the screening that they did when we got there. It was like a spot check of whether people were using masks, what their knowledge was of how to screen people and what they were asking. We weren't doing, like full monitoring like they would typically do, because the quality resource specialist could still do that remotely, but just dropping in and checking up on people. Because what we found when we did that was real concerning, about people's knowledge of what they were supposed to do. We'd get there and they'd put masks on people, like the people who lived there, who didn't have to be wearing masks. And I'd say, can you take that off? And if they can't take it off themselves, they shouldn't have it on. And they don't need it on, you do. So, making sure that they really understood what the rules were, which those then led to a lot more individual education. DC Health around that same time also resumed doing their the surveys that they do of homes, because they're really, as I say, because this evolved, people had a real hard time keeping up with what were the things they were supposed to be doing. The other thing that we saw when we went on the visits in person is you get a better idea of exactly what people are engaged in during the day or not. You get there at 11 o'clock in the morning and see someone still in bed. I mean, those things are a concern. And long-term, those things are a concern too, because, see, you all didn't have this because you're too young, but you can remember back to when we were children in the summer and all we did was nothing. Like, hanging out doing nothing all day, you enjoy, but then you go back to school in September. Kate and I, yeah, that's the way that's how it used to be for us. I know now with my son, we had to schedule his whole summer. But the folks we support now have had a long time, many of them, of having things not scheduled. And some of them might say, you know what? I like watching The Price is Right all day. And so as we now try to get people to re-engage in the community and stop paying providers to have staff home during the day, we have to help people move back out of the house, which, you have to respect people's choices. But I'd like to stay home all day sometimes too, but I have a job to do. I have to pay for that home that I want to stay in. So, you know, balancing all of that as we help people move back is going to be a new challenge. We're starting to work on that one, where we've told people companion is being scaled back. So that you can't just have people at home all the time anymore. They have to start engaging in the community safely.
Right. And a little bit on that, the virtual compliance measurement, was that found to be effective at ensuring that compliance and quality assurance was being met?
The short answer would be no. It's hard to say how effective it was because you weren't doing sort of a, you know, you didn't have a control where you could say, when we did it in person, we found this, and when we did it remotely, we found that. And they were done at different times. So there wasn't an exact comparison. This is just me. I think that there are some things you only are going to see when you're right there, physically there. It's different. You know, you don't get the same sense of the surroundings. You don't get the same sense of, and especially if you have people who communicate differently, communicating through a screen like this is so very different. And you need to sort of engage with the whole person to really understand how they're doing. So I don't think it's an effective way of monitoring if it's the only thing you do. And that's why we really wanted to shift back. We got volunteers from quality who would then do in-person reviews. After early on, the supervisor and I did it. I wasn't going to ask too many people to. But then at the beginning of the year, we got volunteers who were willing to go out personally. Because, I mean, even like in service coordination, where we noticed a family member who reported the conditions of her sister, which you might not have noticed talking to her on the phone, but in person, you can notice that someone hasn't bathed. You might not notice that over, you know, on a Zoom call. So there are things that you might not see unless you're in person.
Right. Yeah, thank you for addressing that. So thinking about these public health solutions again, how did you message these different kind of protocols to the folks in the folks that work in the different provider agencies?
So through our weekly calls with everyone, we started having a weekly forum. We actually started with 2 weekly forums. We did one for the people we support and one for providers, but we found that other people were coming to the one with the people we support anyway. So we switched it to just have one, and then we started having a separate one for folks from Project Action so that we could have an individual meeting with them separate from the big, you know, the 175 person forum. And we've also had our nurse educator has done trainings as like remote trainings for providers. And we required during part of the pandemic, we were requiring regular training by all DSPs, which my view was do it like you don't have to talk about time spent away from the people you support. Sit down with the people you support. And it was just kind of a regular refresher about measures to keep you safe. And it was clear that the DSPs needed it and the people we support would benefit from sitting there with them during it and engaging in it as well. So it could be like a house activity. So we had a regular, I think we required every other week of people, just ongoing refresher about the current requirements regarding PPE and just general health and safety. Mm-hmm. Another thing that was a huge concern of mine and that we, even to date, I get concerned about is maintaining people's regular health care. You know, we got a lot of questions from people, and my answer's been the same throughout. And it's been frustrating for me when I read in someone's record, you know, they haven't been to the doctor because of COVID. And I've just said, that's not okay. Like, And from the very beginning, I said, you need to call the doctor's office and ask them, should we do the appointment virtually? Or do we need to come in? The option of if I have a medical condition that requires quarterly doctor's visits, not having quarterly doctor's visits shouldn't be an option. And it certainly shouldn't be a provider making the decision. The doctor may say, you're okay foregoing that for a couple weeks, but it's the doctor's decision, not the provider staff decision. And we've just seen a lot of people really struggle with figuring that out. I mean, I go to a doctor for routine health care, and I've missed none throughout COVID. So it's I don't understand people missing, especially we struggle to come up with things to do. Well, there's something to do during the day. I mean,
Right. Yeah. And so that kind of brings me to this one question we had for you, and that's to what extent do you feel you were engaged as DDS in the medical community, either through the DDS consult clinician or through different local medical organizations?
I mean, our engagement, we were very engaged with DC Health. We don't engage with people's healthcare providers now, except in the case of people being hospitalized, where we do. Every time someone goes to the hospital, we're engaged there. And then in instances where people, and ask this question to Winslow, not me, but in cases where someone has, I think it's complex health needs. We have like a definition of when we bring in the consultant to advise on a healthcare case. And so there are particular circumstances, whether they're in a hospital or at home, where if someone has a complex health need, it's referred to our consulting physician, and he engages with the person and the doctor. And he, throughout the pandemic, was going to see people at their homes.
Right.
He likes being out in the community.
Gotcha. Thank you. And on the topic of the forums that we were just discussing, how well do you feel like the forum serves the community, and what were some tangible outcomes that you saw come out of that?
You know, it's funny. One thing we've learned is that the definition of the community is apparently broader than we thought. There have been people engaged in the forums who are not people who currently get services from DDA. I'm not sure how they got the invite exactly, but it was very interesting that we were talking about the forum. Now that they've switched to monthly, we were talking about the forum that we had just in June. And Sandy from Disability Rights DC said that after the forum, 3 different people who don't currently get services called to speak to her about the expansion of our eligibility and to ask her questions about whether they might be eligible, what's the process. And she said she didn't realize it was reaching sort of that population of people. And by the same token, there was someone who was calling and asked Charlisa, who coordinates all of this, a whole bunch of questions about decision-making for their brother. And in the course of it, what I learned was their brother gets supports from DBH, not us. And she has been coming to she has attended every single forum because she said it's been very informative. It has helped her, and it's helped her understand what his rights are. It's helped her get up-to-date information about COVID. So those sort of, I mean, we don't have any like formal objective study of what specific impact the forums have had. But we do know that like 175 to 200 people participate regularly. We're hearing from people more than we've heard from people in the past. So it's not just an opportunity to share information, and this is where we're trying to shift it some. It's also an opportunity for us to hear from the community we're supposed to be serving. And it has really, it's been one of the benefits of COVID is that our communication with the people we support in our provider network, I think, has gotten better than it was before. We will never go back to exclusively in-person meetings, I think, and I think we will do better at hybrid meetings because we used to have in-person where someone could be on this conference call, but those were miserable. I don't know if you'd ever called into them, but they didn't work as well as what we're now coming up with our new way of doing it. And I'm hoping that, we'll be much better at those hybrid meetings because it's been surprising to me the good turnout. This is a kind of related. It just happened that it's just a coincidence that it was during COVID. But right before COVID, we had our first Latinx conference, which was a conference at St. Stephen's up in Adams Morgan. And it was our effort to reach out to the Latino community in DC to hear from them about their service needs, about how well we were providing and what needs there were. We did it along with the DD Council and the Mayor's Office of Latino Affairs. It was a conference exclusively in Spanish that provided English interpretation for people who needed it. And our first in-person meeting, we outnumbered the community. I mean, there were like 8 community members. And then our second one was during COVID. And I thought, oh, well, that's it. It has gotten bigger each year. And the most recent one had well over 100 people participating, and it was hybrid. So, people had more resources to participate remotely than we thought they did, and much better ability to do so.
Right. Yeah, that's great.
I do still worry that we're missing some people and that, while we're getting good numbers, that we're not getting comprehensive numbers. But I expected from the Latino community in Adams Morgan that the lack of an in-person option in 2020 would be a problem. And yet we had, I don't know, like 75 people, I think. So.
Great. Yeah, thank you. And so I know that when I was on the provider forums, which I joined a few times, DC Health, there was an individual from there that was contributing. And so we're curious to know, just do you feel like DC Health was providing adequate support in addressing some of the more unique needs of the disability population in DC throughout the pandemic?
Yes. It evolved, not necessarily maybe devolved, but in like the last 6 months, there's been a lot of turnover at DC Health. And so early on in the pandemic, like on Saturdays when they were developing policies, we were on the phone talking together about the policies, educating them about sort of what our different placement types were, what the needs were of the different people, and really working together so that we had a real say in drafting the policies that they were putting out. And early on, I mean, the Sharon Mebane, who did their, she was the one who previously had been responsible for the surveys at our ICFs, extraordinarily engaged. I mean, if there was a COVID infection at one of the homes, she was immediately engaged with the provider, talking to them about how to keep the whole house safe at that time, how to do disinfecting of the home, which, you don't hear about that anymore, but really engaged immediately and helping immediately provide the education. The person you probably heard was either Daryl or Nelson. Both of whom are great. Daryl was fantastic. We lost Daryl to Montgomery County, which was unfortunate. But I think in both cases, they really provided education to people And to the extent possible, we really worked closely together. But I think that as they became more stretched much more thinly, that there was less than communication between them and us. And then we would kind of get blindsided by new policies coming down the pike that we hadn't known were coming. But that was just, I mean, this thing has gone on too long. So I think just the sheer exhaustion of it did have an impact on our ability to work so closely together.
Right. Okay. And so as far as information from DC Health regarding some of these policies, how was that transmitted through the organization to folks like DSPs? Was that through the provider forum, or were there other channels that information might have gone through?
From DC Health, it was posted on their website. As we
Okay.
got it, we would send it out to all provider agencies with the expectation that they would communicate it to their staff. When necessary, depending on the particular guidance that they issued, when necessary, there were times that the nursing roundtable, which is the discussion amongst all the nurses at the provider agencies, DC Health would come and explain issues related to new guidance that they had. But direct education to DSPs, I think we expected more that would come from the provider agency to the DSP, and we provided the information to the provider agency.
Okay, great. And were there any times that DDS offered DC Health some opportunities where you provided them with maybe feedback on care for people with ID that might have been beneficial for them?
Oh, yeah. Well, was it beneficial? It was intended to be. I mean, as they were developing their policies, and the whole discussion of, are the people that work in our placements healthcare providers or not? They were coming at it initially seeing our ICFs as though they were nursing homes.
Mm-hmm.
And they aren't. And I'm like, if you went in, it would feel like a house to you. Think about that. And so think about if you're saying that people can't eat at the same dining room table, how difficult and disruptive that is. So really educating them about the reality of what our placements look like. And because of the turnover, it meant educating and educating and educating. But yeah, there were opportunities for that. As I say, I think that we did better with that at the beginning. And then later on, it was just that, they didn't have the time to spend that they had earlier on, maybe. And so sometimes things would get drafted without the input, and then we'd have to, we would still then provide the education, but you prefer to do it before it's final.
Yeah, certainly.
But we could still reach out, and, worst case scenario, then I would call LaQuandra and say, we need to talk about some of this.
Mm-hmm. Great. And what was the response of the people supported to all of the public health measures that were being put in place from your perspective as the director?
The first thought that came to my mind was confusion. And if you think about it, think about how complicated it has been throughout this whole thing for all of us. Mm-hmm. And like I said before, we're in this system that has always imposed so much on people. How much are they able to say, no, I don't want to do that. I'm going to go out now. Thank you. Really being able to make decisions in their life. Yes, it's true. This is what would keep you healthy. This is objectively the best choice in terms of your physical health. And what are you going to do? But very often providers are not used to getting to that last question. I can think of an example of a person where the provider did it very well because the person, and it was pretty early on in COVID, liked to go out, liked to bring women home, generally different women each time. And so he was exposing himself to a lot of different people. And the provider said to him, those are your decisions. We're concerned And you need to think about, you're exposing yourself to many different people that could expose you to COVID. We also have staff though. And we're concerned about our staff's health. So as you're engaging in behavior that feels like it's putting you at higher risk, we're going to pull our staff back a little bit. We're still going to check on you, but here's how that's going to look, because we're not, and in fact, the person did get COVID, and they did continue to provide supports, but they let him choose how they provided those supports in a very respectful way. I really liked in the summer of 2021, where we worked with a number of stakeholders and advocates to come up with the decision-making discussion that we wanted everyone to be having. When we developed the CPAC, and I'll remember what that stands for in a minute. What does it stand for? I know it's Assessment Questionnaire, Community, but what would the P be? But anyway, when we developed that training, we really attempted not to call it a training. It was a PowerPoint that was to guide a discussion, and it was around who holds the decision and how do you help people make these decisions. And it was a really good, I thought, really well thought out process of helping everyone understand, and it really community participation assessment and questionnaire. And that's on our website, and you can see that. And that's the team walks through this with the person in determining, what's their readiness for going back into the community as things were opening up. Making decisions about when to re-engage, how to re-engage, what feels safe, what kind of measures they need to take. And when we introduced that, we also then introduced these discussions about decision-making. And how do you help someone make these decisions? How do you respect whose decision it is?
Mm-hmm. Right.
Which is a huge issue for us all the way around, before COVID, in terms of, the tendency to infantilize people with intellectual disabilities and to believe that you have to tell them what to do, as opposed to help, provide the support they need to make the decision in their life.
Mm-hmm. Yeah, certainly. And so, is there anything that you wish, looking back on all of this, that maybe you would have done differently if you were to do it all over again?
No, I never want to do it all over again.
For the next crisis.
Exactly. I want to be retired before the next crisis. It would have been nice. I think it would have been helpful to have engaged more in the development of the Appendix K, as opposed to presenting the draft to people, just presenting to people, okay, we can have flexibility. What do we need? Because, here we are 2 years in, people said it needs to include increased nurses' wages. And I'm like, why didn't you say that in 2020? Because we could have included it in 2020. And so I worry that we didn't, I think that we were, and, it's the same thing I was saying about DC Health before. We were so focused on getting it done that some of that process, because, some of the process of really engaging people, hearing from people, slows things down. And so, being able to have a good combination of getting input from people and being able to then incorporate the input and get the product finished, might have made for some better decisions about what's included in our flexibilities in our waiver. I don't know. We just looked at what other states were doing and copied it. Mm-hmm. I'm a big fan of copying.
Since we're going to have folks that are going to be reviewing the transcription, both from the study perspective, but also from an educational perspective. Can you just elaborate a little bit more on the document so that folks, when they hear the term, they'll appreciate what it is?
Yes. So with the waiver, you can have, when there is like a public health emergency, which, some states were so well prepared for this because states like Louisiana, Texas, California, they do disasters like regularly. And so when it came time for them to have to incorporate flexibility into their waiver, which meant that you could waive some of the waiver rules, you could change some of the waiver rates, you'd get permission from the Centers for Medicare and Medicaid Services to make temporary adjustments to your waiver to address the current emergency. So it's like an emergency amendment to your waiver that's only in place during the pendency of the public health emergency. Now, this one, they haven't extended it yet, but it will be extended currently until October and maybe even beyond. So it will have gone on then for 2.5 years, which is just unprecedented. But typically then states would get the opportunity as this emergency happens to ask CMS for the flexibility. And maybe part of not having a process where we sought input from people and spent more time developing it was just that we thought that it would be over by the summer. And so we were trying to write in these changes because we wanted to get things immediately in place, like, shifting the staffing at our homes, those kinds of things, paying a different rate for people, to get those changes in immediately, that we didn't want to take the time. But then you look back on it and you think, oh, well, it was going to be retroactive to the beginning of the public health emergency. So we could have taken a little more time.
Got it. Thank you. I'd like to shift gears a bit to some funding resources. Dr. Bill, did you have a question?
Yes, I did. Before we shift gears, since we're talking about what you feel would be appropriate now that you have the wisdom of having gone through all of this, as focusing on the health piece, and we had asked earlier about the engagement with the medical community, are there ways that you feel that perhaps engagement with the physician provider community or the system of healthcare that extends beyond Department of Health, of course, would have helped to either inform how to develop policies, how to develop these recommendations that you were then sharing with Department of Health, how to develop messaging for the community as it relates to specifically COVID-19, importance of testing, what the tests mean, et cetera, et cetera. Is there ways that you think that we could have creatively, cooperatively worked more with the healthcare community or with community health centers, federally qualified health centers, or other entities to have made this a little bit more of a holistic partnership as opposed to Department of Health exclusively?
I think we would have had to identify, like you said, maybe the federally qualified health centers, but identify some providers who support a large number of our folks who have the ability to engage in that manner. Because you may know the whole range of the folks we have who provide care for the people we support, and it is a whole range. And some, I think, you're right, it's a missed opportunity to have not engaged with, I can think of just a few, but like a few providers who really were getting tremendous experience in terms of the number of people they were seeing, understanding kind of, not just the COVID impact, but beyond COVID, we lost more people in fiscal year 2020 than any other year, not even from COVID. And so, you had, and I know like during flu, one of the things they look at is like excess death. And that's what we're wanting to look at now is kind of what was the cause of these excess deaths that year. And I expect there could have probably been some benefit from engaging those providers. We don't tend to be involved with them. It's like we're, like the provider makes the connection to them. And so that it would have been good to make that connection. It's like 3 removed from us, but it would have really been good to pull them together to learn from what they were learning and to then provide the support that needed to be provided so that people could get to them.
I'm also thinking in terms of a multidisciplinary or transdisciplinary type forum that we could, would that have been something helpful to have engaged in expertise around this, just as we did the community forum? But of course, the community forum was for a specific purpose that would not necessarily have focused on systems improvement and integrating better with the health as well as DC Health and DDS. Perhaps having that also as a forum to bring people together, not necessarily having the expertise around, ID, but also having expertise in other phases of crisis management, pandemic, health in general. Could you see that perhaps going forward, even thinking how that could be creatively part of your preparedness, your readiness for the next crisis after you're retired?
Those will be good notes that I'll leave for my successor. But no, you're absolutely right. I think that, and the problem is because we don't, it's like, we engage with providers who engage with the health provider. And because we don't have that direct connection, it doesn't occur to us to bring that together, but it would be helpful to work with the providers, with the various provider networks that we have, because it's not just the physicians, but also the other service providers of people. Although those service providers were coming to the forums, but with much more specific questions.
Right.
Can I do this remotely and still get paid?
Right.
As opposed to,
right.
And I think it would need to be a much more kind of guided conversation. You'd have to be really clear about what you were trying to get from it to really learn from each other about what people were seeing and how we could work together to maximize the health benefits to the people supported.
Right. The other area, perhaps opportunity, is with the, I think, resource specialist that was also being used in, I don't want to say monitoring, but it is part of what they were doing, or providing education and making sure that everybody was kept safe. I am curious in terms of the educational provision that resource group was offering as it relates to their own understanding and their own background around this, because that's obviously probably the main area that folks at the homes were getting education beyond seeing what was posted from DC Health, but it was more individualized through these resource individuals that were dispersed to evaluate what was happening in the homes.
I think the better education was probably coming from the nurse consultants, because they're also, each of them has a certain number of provider agencies, and when they needed to strengthen the education in a particular provider, we would engage with the nurse consultants, because the quality resource specialists that wasn't necessarily their area of expertise.
Okay, so the education that they were doing was mainly just pro form in terms of what they were seeing, masking.
Exactly. And, right. And so they would be given training on here's what you need to tell people and they would tell them, but really understanding it if when there were gaps that we saw where we needed to strengthen a provider, we would send the nurse consultant.
Okay. What I'm just curious in terms of their training and their background, because I am not as aware of the nurse consultants and their role. Were they sort of infectious disease knowledge, or was it more general nursing and what they acquired through the pandemic?
Yeah, it's more general nursing.
Okay. Is there an infectious disease consultant or someone who you do have as a resource person, especially given the nature of this being so specialized around infectious disease virology and that kind of thing?
I mean, we've relied on DC Health for that.
Okay.
And Dr. Nesbitt was a public health physician, so.
Right, but that's within the context of DC Health. And we are going to interview Dr. Brown, but I am curious in terms of his similar question asking you around how do you think we could have utilized you in a broader way. So I am curious from your perspective. I'm going to ask him the same question. How do you feel we perhaps could have utilized Dr. Brown in larger ways beyond the medically complex cases that obviously would require his attention around prevention, around morbidity, mortality, hospitalizations, discharge, et cetera? Is there a larger role that perhaps he could have played? And you may say I defer to him, but I
sort of defer to him
and
Winslow, only because Winslow has more, like Winslow works directly with him. He does all the referrals to him, so he'd be more knowledgeable about exactly sort of the scope of what he would hope to get from Dr. Brown. I only know of Dr. Brown from anecdotes that get to me.
Okay.
So
I was just thinking in a sort of an ideal world, if I had this physician, this expert who I could, how could I maybe use this person in different venues? So, okay, that's fair enough. All right, Kate.
Yeah, because to me, what he has been is this very hands-on, on the ground physician who is, from notes I read, wonderful with like families and guardians and helping them understand what's going on and helping them with decision making and really giving good information about the status of things. But that's been sort of the scope of what I've seen of what he does.
Right, but in terms of the collaboration, say with the nursing roundtable or educating within the system, that may be a gap that could be a helpful futuristic type improvement. Okay.
Yeah, I don't know that it would be him or that position, but yes, I agree.
Exactly.
Although I will also say that Daryl, whose last name escaped me for a moment, filled that role really well.
Yeah. And unfortunately now is gone.
Exactly. But she was a public health nurse, really knowledgeable. I mean, I don't know if you, Kate, were ever at forums that she was at, just very knowledgeable, gave really good answers, was a really good educator. Because she had such a good understanding of things and was able to communicate them in understandable English.
Right. Yeah, so I know we did want to ask you a few questions about funding during the pandemic. So I'll just start by asking if you felt that DDS was adequately funded both at the federal and local level during the pandemic.
Absolutely. So one of the biggest challenges has been from the beginning of the public health emergency, we had enhanced federal match for our waiver. So there was an increase of 6.2% in federal funds allocated to pay for waiver services. And then for 1 year with the American Rescue Plan, we had an additional 10%. 16.2% of $300 million is a lot of money. And the challenge there is you get this huge influx of funds that have to be spent immediately, that cannot create any expectation or ongoing obligation because they're going to be gone. And so, you know, the challenge is one I don't like to complain about much, is that you have this temporary period of time where there's way too much money. Because people don't like to hear that problem. But it is, you've got this huge influx of funds, and what can you spend it on effectively to really make a difference? I mean, one of the things that we really hope to be doing in the next several months is really kickstarting our technology efforts, because it's going to allow us to purchase equipment and to really make some of the changes that I wish we could have made in 2017, but we can take advantage of these funds being here to purchase equipment, to get providers trained, to do a lot of the upfront work that needs to be done to really make a shift, to get people comfortable with the idea of what does it mean to be tech first, as they say. But what, you know, how do you use technology in a manner that really supports people, allows people to live more independently, you know, and is a support to people as opposed to leaving people more isolated? How do you use technology in a way that's supportive, that still keeps their safety and their progress in view? And I think I'm really hopeful that with the resources we have, that with our waiver renewal, that we will be doing in 2020 what we hoped to do in 2017, or in 2022 and fiscal year 23. We'll be doing what we had hoped to do in fiscal year 17 with our last waiver renewal, which is really introducing this. So, you know, those funds were helpful. We hear a lot about wages and the challenge of the workforce and wages, but you can't increase wages during a public health emergency, because then at the end they go back down again, and then you're going to have a terrible crisis. And so figuring out steps that you can take in that regard is one of the other challenges. And that was where I had said it would have been helpful to hear more from people, but it is hard for people because the first thing we heard from everyone was just pay people more money. Well, you know, this thing's going to end and then their wages are cut. So let's come up with something that can be that can benefit from a short-term infusion of funds. And that's difficult.
Are there
to figure out?
Yeah, are there mechanisms that, because I heard this a lot from throughout the interviews, but are there mechanisms at your administrative level as you're negotiating and leveraging for your funds that are required each year that can indicate the capacity need? Yes, you're maybe ramping up in terms of the workforce needs, but certainly some of that workforce needs is going to have to continue. It's not just simply going to be return to normal after a pandemic. There's going to be changes that are going to happen, in other words, that are going to need to have some of that supporting structure after the pandemic, right? It doesn't just go back to 2020, 2019. So I'm just curious as to how that could weigh into those decisions around increasing wages because of the foreseeable changes that are going to, be needed as part of the infrastructure, as part of the capacity building, and obviously now because of the change in eligibility too. Those may factor into the argument as well. I don't know.
And it's all part of this really, I mean, when you name just those things and then try and figure out how do you plan for a budget next year when how people receive services whenever this thing ends, is going to look different.
Mhm.
And what's going to be the cost of that? It's a guess at best. I mean, so, trying to figure out what will the services look like then, because part of what we see is probably more individualized community-based services, which generally are going to be more expensive.
Mhm.
So how do you factor in that cost? And then, the issue of the need for enhanced wages for DSPs, but once you hit DSPs, it then goes all the way up the line, because then, well, what about house managers? What about queues? So you get all of those. And as you said, the expansion, how many new people are going to be coming in?
Mhm.
And so when we look just at typical growth in the years prior to the pandemic, our waiver budget was going up about 8% a year. That's a lot on a, now $300 million budget. And so when you're talking about, okay, and then add these other things on top, what I think people miss sight of sometimes is no matter what all you plan to do, at the end of the day, the pie doesn't grow.
Mhm.
So you're cutting some of someone else's piece out if you're growing your piece.
Right.
And so if ours has to grow by that much, whose is getting smaller?
Right.
Somebody's has to. Or you're going to turn around and ask taxpayers to raise their taxes.
Right.
Like, it's limited choices there. So
Right.
the budget development is miserable. It is one of the reasons I had brought up that one of the things I'd like to go over in the forum is like breaking down pieces of our budget to help people understand everything that's in it, because I don't think people fully get it. And they could then testify in a much more informed way. I mean, they're still going to ask for more than what we can do. That's the way it should work. I mean, because if they don't keep pushing, they're not going to get anything. So, they may push and they may ask for more than what is available, but it would help for people to fully understand, because as we move forward, I don't know if I'll get there. My dream would be if we had some way of addressing how we do residential supports so that we are maximizing the ability to benefit from federal housing supports that should be available to the people we support. We spend about $20 million a year on that. And so, if you could reduce that by half, if you could have people getting their own vouchers, living in their own home, having people who actually have supported living instead of what looks to me like just a really small res hab.
Right.
I think that would help our budget, and I think it would create circumstances where people live really much more truly independent lives.
Right. Yeah.
But it requires a real shift in how we do things.
Yeah.
On the topic of the technology that you had mentioned, throughout the pandemic, before some of this financial infusion happened, were the funds directed at technology enough to cover what was necessary to allow for sufficient connectivity and sufficient personal technology use for folks that are supported?
Yes, but they weren't utilized. So, we did amendments to our waiver in 2017 to introduce the idea of technology. But we introduced it in a way that sort of said, providers, go ahead and do it. You can provide up to 20% of the service that you provide can be remote. You can use, it's up to, I think, $5,000 to purchase equipment for people. So there was ability in the waiver, but there wasn't enough. We've never functioned that way in DC. We tell them what to do and they do it. it isn't that, we have very few providers who have that kind of creativity. We have one in terms of technology who has done it. We have another one who's out there who's very creative. But, once I get past one or two, maybe three, I can't think of many more who really on their own go out there and try and figure it out. Most of them. And it's the system we have had. So it's like, for years, we told them what to do and expected them to do it. So you can't then on a dime say, now you just go do it and we'll, because they're used to, if they go out on their own, we, smack their hand. So it wasn't the best way to introduce it. That's why I say this time we really are introducing a lot more technical assistance and support to help people learn how to do it. But in 2017, the resources were there, but not really the technical assistance and support that people needed to actually make the changes.
Right. Have you expanded your technical support within the agency? Because I attended a couple of those. They were far and few between. And as you said, people were not very creative in terms of how to develop that educational piece for themselves. And most people really didn't benefit from, I think it was an excellent attempt to do that, but in terms of the content, it was definitely more complicated than what most people actually who did participate could actually manage and then take away and actually implement themselves.
So there's this shift, which I don't know if it stands for something, what it stands for, but shift training. And a provider can be shift certified as a provider, which does teach them the skills to really implement technology into their services. And so we, through the use of ARPA funds, have paid for providers to complete that training. And I think we have 19. Actually, I think we paid for 19 and we have 11 who successfully completed it. But we paid for providers to be able to do the shift training, and we're paying for more providers now to do it so that they really comprehensively learn how to implement that.
Yeah, because you had the fundings that were available, but it was hard to know how that funding, was really going to be used.
Exactly. And that's why with the shift training, our hope is that it will really show people how they do it. And then some of the modifications in our waiver really guide the way as well. Because it really changes what the rate structure is for doing remote supports.
Right. Did you feel there were any gaps in funding for services during the pandemic?
Providers will disagree, but I would say no, just because we had more money than we could spend in the year. And that was the challenge of how do you make the necessary modifications in the waiver to be able to reimburse what's needed during the pandemic. But I wouldn't call it gaps in funding, because to the extent we could come up with the plan, the money was there.
Now, because you're right, providers did bring that up. Is the DC Coalition a proper representative agent to collaborate through some mechanism within DDS to kind of come through some resolution around that, or to again explore how they could in fact access those funds in the appropriate way with the waiver?
We meet with them every 2 weeks. So we do try to collaborate with them around these issues. I think some of it is more related to the workforce challenge of not having people. And then because you don't have people, you're paying the ones you do have time and a half. Now, at the same time, at the beginning of the pandemic, they were laying people off. So it's hard to talk about a workforce crisis and furlough people at the same time. Except that at that time, they were trying to minimize the number of people who worked in each placement to reduce the risk of bringing COVID into the placement. So there was a very, like legitimate, logical reason for the decisions that were made. And I think that, I'm exhausted. I cannot imagine the direct care staff, how that must feel. Just in terms of, like for them having gone through this now for what, 27 months so far, with no break, it's exhausting. And so I think that that's caused a lot of turnover in their staff. And there's a lot of jobs out there.
Yeah.
And, at that level, people have lots of choices.
Yeah.
Right. And potentially, given what you've already said, I don't know, you might answer no to this, but we'll see. Did you advocate for any additional funding? And if so, how effective were you in getting additional funding?
Oh, see, I have a stock answer for that one, so there's no point asking me.
Right.
The mayor always ensures that we have adequate funding to provide for all the needs of the people that we support.
Right.
So if I asked her for more and she said no, you would never know.
Right. My thought was that you might have answered some of the earlier questions with gaps that would need to require additional funding. But you had said that you were adequately funded from the beginning, so I knew that the next series of questions would be different. Okay.
Yeah, I one time before I was in this role, when I was the deputy for RSA, in our budget hearing, I think, the council member asked, if I was to give you $1 million toward this, what would you do with it? And I didn't say anything, but my eyes said everything, and we were reprimanded later. Because there's an answer to that question, and it is, I don't need that money because the mayor has provided adequate funding. Thank you very much. And that's not this mayor, that's any mayor.
We did want to ask you a few questions about vaccines. Starting with, how many of your staff are vaccinated at this point?
98%.
Okay.
And 94% who are able to be boosted have been boosted.
How many of the people that are supported are vaccinated?
I think it's 77%.
Okay. And how did you promote vaccines to the people who are supported?
So it was a lot easier to do in the placements that we have. And, that has evolved too, because in the very beginning, everyone wanted a vaccine. For a short period of time, it was, why can't I get mine now? Before people started saying, oh, no, I don't want that. And so we were pretty successful up front. We had sort of vaccination, DC Health, along with Department of Parks and Rec, and Giant coordinated vaccine clinics. And so all of our folks who were in placements were able to go and get vaccinated. And like our ICFs are at 99.6% vaccinated. Residential habilitation is 100% vaccinated. Supported living, 94%. So, those host homes, 99%. So, it was done by, I think the most challenging has been the education for the families that, where people live in their natural home, because that's at 76%. We have nurse practitioners who are assigned to people who live in natural homes, and so they've provided education to those families. Every person who is not interested in a vaccine, there's sort of a process someone goes through because they're declining a necessary medical intervention, and so they have to walk through sort of, has the person been educated about it? are they making an informed decision not to have it? And so the service coordinator for a person who lives with their family, or the someone with the provider agency for folks in placements, walks through that with someone and revisits it with them. And so that's overall, it feels like things have gone very well. There is still some of the gap in natural homes. And, unfortunately, we had 2 people hospitalized in June. Both of them were current with vaccinations, like both vaccines and a booster within, less than 3 months of having gotten COVID for a second time and ended up in the hospital.
How did, as far as boosters go, because it's been a whole new wave of campaigns and such, how has the promotion for boosters been going with DDS?
Fair. Part of the problem too with boosters is, after the first booster, whether you need a booster is a very individualized decision. I mean, it's easy if you're over 50, but for other people, it really is a question for your doctor, should you have a second booster or not? So how we track that and make sure people are following up with it is a little more complicated than it was when it's like everyone just needs to do this. And when I look at overall, we have 77% of people who've gotten boosters. But broken down by placement type, it's 43% of people in natural homes have gotten boosters. 90% in res habs, 97% in ICFs, 85% in supported living. And so, the big gap once again is people in natural homes. And that's 43% of people eligible for a booster have gotten a booster. So, we got over the hurdle of, do you need a vaccine? And then they said they didn't want the booster. Mm-hmm. And I hear that from other people, like from people here at work who, it's like, really? They're like, oh, I've already done 2. Well, get another one. It's like, it's just a shot. But it's been challenging. But there is that underlying sort of mistrust. And, it's true even like, it's a resistance to all kinds of, because when you ask, do you get a flu shot regularly? No, I don't do that. I mean, that's more a question for you. I don't know how you deal with that. I mean, it's very challenging because you are coming up against a feeling, not a reasoned decision.
Right. Are there avenues within the nursing roundtables or other areas of education that you are able to address this messaging issue? I think it's just a problem throughout the system, but particularly so with individuals with disabilities, where you have other nuances that are factored in terms of their understanding. Certainly not at your level would you be engaged in that, but do you see that as an important priority, and is there somewhere within the system that can be addressed? Because I don't foresee that these numbers are going to be improving without some additional support for through messaging that is more individualized to the population.
Well, and they pulled back on the booster requirement.
Right, but that doesn't mean.
And so look at the message that sent to everybody, right? Because as soon as they pulled back on it, those numbers with our providers have not budged.
Right.
And I've told them it may come back. Yeah. Like, it just because they allowed the emergency to expire and it's not there right now, it may still return, and you need to be ready for that. And I will tell you, the provider we have who instituted a must be current with vaccines mandate in December of 2021. All their staff are vaccinated and boosted because it was just an expectation. You know, we've done this and continue to do it with the nursing roundtables, with individual education with people. It's like, I don't know what you then do next, because people get tired of hearing from you. They're like, yeah, you've told me this, and I've told you I'm not doing it. It is a major frustration. I mean, it's like, you know, this vaccine came out so quickly, and could, you know, really change the trajectory of this whole thing, and for people to be resistant. I guess I'm not understanding enough of all of the underlying issues that cause people to not trust the system.
As far as the clinics go, has there been any plans, or have there already been specialized clinics for boosters for people supported?
No, only because we did them early on, because you may remember vaccine distribution was limited. And so the availability of getting a vaccine was challenging. If you remember people having to call repeatedly or log on and try and schedule an appointment on their computer, and it was hard to do. So being able to schedule a time for everyone was the issue. You can, you know, you can walk in and get a booster right now. You can call and get an appointment within the week. And so the availability of boosters is not the problem.
But again, thinking around the sort of system improvement with the interface with health and community health centers, perhaps there's some leverage there that maybe, you know, DDS with a partnership with federally qualified health centers could be used. I'm thinking specifically also about Randy Abramson from Bread for the City, who has been, you know, wonderful.
Well, because when you raised it before, she's like one of the only people I could think of who we could partner with. But
right. But there are others. But again, that would take a deliberate approach to finding who these people are and which health centers, you know, Community of Hope or certain centers within you know, the community right now with Unity. So they're there, but you know, how do we approach identifying them? Yeah.
And the challenge is you have to get people to go to them. I mean, that's the benefit, is that Randy can go to people.
Right. But the primary care physician, if they're linked through that community health center, can be that conduit too. And therefore connecting with them in a more formalized, you know, intentional way may be another creative approach. Yeah.
So I know we talked about availability as a challenge to getting people vaccines, especially towards the beginning of the vaccine rollout. Were there other challenges that came up in getting people vaccines?
Just all of the mistrust of the healthcare system, of how did this vaccine come out so fast? Are you wanting to experiment on me?
How did you counsel people who didn't want to receive the vaccine?
We have a process that we go through. There's like a series of questions that people are asked about how they made the decision. And then we revisit it and revisit it. And that's done, as I said, it's in natural homes, it's done by our nurse consultants and our service coordinators. And then in placements, it's done by the nursing staff at the various placements.
So a medical professional.
But people have these views. Even medical professionals have these views. So, you know, the percentage of, well, anyway, yeah, it's just because they're a medical professional doesn't mean they don't also have those views. And if they had those views and are vaccinated, that's wonderful. But, you know, like, we know who in our agency has and has not been vaccinated. So.
Right. And a few final questions for you. How would you utilize the physician consult again in order to, sorry, that was poorly phrased. How did you utilize the DDS physician console as an educational resource during the vaccine rollout process?
I don't know that we did. I don't believe that we did. I think that we used more our nurse educator and our nurses than we did the physician.
Yeah. Dr. Wolf, do you have any further questions? That brings me to the end of my question list.
Because we would have always turned people, I always, when people had questions, asked them to talk with their own doctor, because I assume that's who you have the most trust in, as opposed to a doctor.
I think that question was more system oriented in terms of how utilizing your clinical expertise in engaging with the nurse educators, the nurse liaisons that are operating in the homes as a resource more than how specifically on an individualized basis your clinical physician would be utilized, but more of a systems approach.
Well, and for that also, DC Health helped with that because they came to our nursing roundtables to provide education as well.
And they also produced a video, which I have not been able to get a hold of. Apparently, during one of our interviews, we were told that there was an excellent video that had been produced through DC Health. And it was utilized at least one of the provider agencies, and it was very good, but I have not been able to find it. I'm not expecting you to know about that, but I heard it was a very good tool, educational tool. Yeah. Yep.
Oh, yeah, I don't know. Winslow might know when you talk to him, just because he has an every other week meeting with DC Health. So
yeah, I only bring it up because it may have been helpful for wider distribution. If it really was very good, then having these tools certainly would have been helpful for all of the provider agencies to have access to. Yeah.
Well, and I think honestly, the biggest challenge is how do you get into the natural homes to have those conversations?
Yeah. Yeah, it's tough. I've been doing that on a very individualized basis because of physicians who have, contacted me, but you are absolutely right. That's the challenge. Yeah. Yeah.
Yeah, because when I look, I mean, overall numbers, if you leave them out, we're above 95%.
You're good.
Like, yeah.
Yeah. Speaking of which, Kate and I had talked about, again, maybe we should formally end our interview, because I was
Oh,
going to
okay. Well,
ask
let
you
me,
about
I'll stop the recording then.
yeah. I was just going to ask you a question.